Hi guys, this is Charity Stanley, and today we're talking about kidney disorders. So this poor kidney that we see on the screen, this is one that has polycystic kidney disease. And so as you can see, polycystic means multiple cysts. It has multiple cysts, and on the inside of the kidney, it is not a fully working kidney due to the rupturing of those cysts, and the kidney output and the amount of urine and toxins that are removed from the body are drastically decreased in patients with polycystic kidney disease. So first concept that we're going to be talking about is pyelonephritis. Okay, pyelonephritis is what happens when you have a urinary tract infection, and that urinary tract infection either isn't treated adequately or it's just a very virulent strain of bacteria. So the bacteria is localized in the bladder, but then it starts to climb up the ureters to infect the kidneys. So you either can be infected acutely or chronically. Acutely is typically an acute bacterial infection. You have problems very quickly, start running severe fevers. You can even have an abscess on the kidney that would have to be drained. That is when pyelonephritis tends to get very, very messy. Additionally, chronic pyelonephritis happens with repeated urinary tract infections. And so, if these infections aren't treated completely, then what happens is some of the bacteria live and it becomes survival of the fittest. So the strongest bacteria are able to bypass the antibiotics and still live. And so you're going to be treating more difficult organisms to kill. So reflux is another term you're going to hear in relationship to pyelonephritis. And reflux is the fancy word for the when urine starts to back up due to these abscesses and starts to back up and go and remain within the kidney. It can't actually get out of the kidney due to the abscess creating an obstruction in the ureters. So these kidney abscesses actually have to be drained in IVR under fluoroscopy because the kidney is a very vascular organ, and you want to make sure that you're not causing more bleeding. So acute infection can happen without obstruction or reflux. Chronic is where you start to see the structural problems where you have the urine backing up with the reflux, and it's often caused by fecal bacteria, E. coli and Enterococcus. So the obstructions can also be from stones or previous stones that have created scarring within the ureters. Can happen from decreased bladder tone that often happens with neurodegenerative diseases or with neuropathy within the bladder. Pyelonephritis is most common in young women that are sexually active, and it's also common within pregnancy and is a common cause of premature labor. One of the big things to recognize within older adults is when they have a urinary tract infection or pyelonephritis, confusion will often be one of the first symptoms. They stop having the ability to feel the burning sensation that's characteristic of a urinary tract infection. And so with pyelonephritis, you need to find out, is there previous history of kidney stones? Could there be potential scarring in the ureters? Find out about pregnancy before exposing to fluoroscopy dye and other radiographic imaging. Need to be doing assessment on the flanks and doing consistent assessments on the cardiovascular system as well. So anything that pertains to urine, people tend to get embarrassment about, guilt about. Also need to check about diabetes, because diabetes, the sweetness of the blood can actually feed the bacteria and contribute to the difficulty in clearing these infections. So your assessment, there's several things you need to assess. Urinalysis, blood cultures to see if we have septicemia, that is bacteria within the blood. Look to our WBC count to see if we have differential. Differential is where we, going back to hematology, that's where we have a shift to the left with a bunch of new white blood cells being developed in response to infection. C-reactive protein and our SED rate, ESR. Both are indicators of inflammation, and inflammation can make pyelonephritis worse. And big things that you will see within the UA is you may see spilling of white blood cells. You may also see that it's positive for leukoesterase. So this indicates that there is bacteria within the blood, or I'm sorry, within the urine. And then imaging assessments. We often will do a KUB. No, that is not Knoxville Utility Board. What that is looking at the kidney, the ureters, and the bowels. So it's a lower abdominal pelvic type x-ray. And then CAT scans will give us lots of information on this. So when we have a patient who is experiencing pyelonephritis, they're going to be reporting significant pain in the back, may also have pain in the abdominal cavity due to inflammation and potentially infection. And if the patient has chronic kidney disease, this pyelonephritis has been going on for a while, kidney tissue can actually die and create additional problems for the patient. So how do we manage this pain? We need to make sure that we're doing non-surgical management of pain. Is going to be the first thing that we do. We'll be doing heating packs, patient position of comfort. If we do have to have surgical management, we are likely to have to require stents. And so to help open up some of these areas of cavitation and scar tissue that have happened from the pyelonephritis. So managing pain non-surgically, we need to look at Tylenol versus NSAIDs. Okay, Tylenol is one way to help block the pain signal, can be used at the same time as NSAIDs. However, NSAIDs, we have to watch their use within kidney disease because NSAIDs are actually cleared by the kidneys. If the kidneys are showing problems and having symptoms of disease, then it may be detrimental to the kidneys to be using NSAIDs. So patients will be using antibiotics to treat the infection. If the patient has a catheter needs to be replaced after 2 weeks. So if it's been over 2 weeks with a Foley catheter in place, that sounds crazy within a hospital environment to have a single Foley in that long. But within the home environment, the patient's sent home, then it is possible for them to just change the catheter every couple of weeks. From a nutrition standpoint, we need to make sure that our patients are eating adequately and that they are getting at least 2 liters a day of dilute urine. So to make that much urine, we're going to have to be drinking a lot. So pushing fluids as well, as long as there's no reason to stop that due to the patient's pre-existing kidney issues. So surgical interventions include a pyelolithotomy. Pyelolithotomy, and this is where we remove the stone from the kidney. And so a nephrotomy is where we're making an incision into the kidney. A nephrectomy is where we remove a kidney. We may have to do rerouting of the plumbing between the kidney and the bladder. That would be a ureteral diversion. And if we're having to repair the ureter, we actually call this a ureteroplasty. And so this is where we're doing a ureter repair or revision based upon the patient's symptoms. So home care management need to make sure the patient understands what kinds of self-care is needed, that the patient is eating enough protein to help repair the tissues, but not too much protein to cause further kidney damage, and make sure they're taking their medications. Need to make sure that the patient has rest periods. We need to cluster our care because kidney disease takes a lot out of patients. If they've been prescribed antibiotics, make sure they're taking all their antibiotics. And they may need help with home health care through nurses or aides, and also assistance with housekeeping. So ideally, our patients will be reporting that the pain is controlled and that they will be knowledgeable because we educated them as nurses about what's going on and ways to prevent or reduce progression to chronic kidney disease. Okay, our next disorder is acute glomerulonephritis. This can be primary versus secondary. It's primary if the problem is actually within the glomerulus with the kidney. Okay, there is a structural problem within the glomerulus. It's secondary if it's a systemic disorder that has contributed to the acute glomerulonephritis. So what's the big causes of glomerulonephritis? Big thing is hypertension often leads slowly to chronic kidney disease. Once the kidney has started getting involved and is deteriorating due to the chronic hypertension, the patient often is anemic, and this is due to decreased erythropoietin being secreted from the kidney. You'll often see swelling. And in acute glomerulonephritis, there's often an excessive immune response to an infection. So often, 10 or so days after an infection, then you will start to see problems with the kidney. This is very common with strep infections that have not adequately killed all the bacteria. So big things we need to assess is find out about recent infections, any previous surgeries, inspect the skin, check for any kind of upper respiratory infection, strep. Piercings have also been found to be a common cause of glomerulonephritis, and you'll see changes in urination. So the baseline blood pressure needs to be examined now versus the baseline to see how the blood pressure has changed in conjunction with the glomerulonephritis. So lab assessments. With glomerulonephritis, big things we're going to be doing is looking at a UA. UA will tell us if there's hematuria, if there's blood within the urine, there's protein within the urine. Are we spilling red blood cells? Are we spilling protein within the urine? And so our serum albumin will often be low. Our serum creatinine will be elevated. Our BUN will be elevated, and the GFR, glomerular filtration rate, will be reduced. So basically, when you're thinking about this, your serum albumin is decreased because the proteins are stuck fighting the infection and the inflammation within the kidney. Your kidney gets upset because there's a war going on within it. So your creatinine increases and your BUN increases. Now, if you have antibody bacteria complexes stuck within your glomerulus, your filtration rate is going to be lower than it normally is. And then we may also need to do a kidney biopsy. Kidney biopsies are done in IVR and they are very painful procedures. So we need to manage infections. Take all of the course of antibiotics. Again, strep is a common cause of glomerular nephritis. So after antibiotics, patients are often prescribed steroids to decrease the immune system response. And we will monitor their fluid and electrolyte balance and check for new onset swelling, new onset dyspnea, and check to see if the patient has crackles because often fluid retention follows. If you can't get rid of the fluid, you're going to start to retain the fluid and it will end up affecting your breathing. Chronic glomerular nephritis. This happens over a long period of time. They really don't know exactly what the cause is for it, but what they do know is postmortem exams, you can see deposits from immune cells and infections that are left within the glomerulus. So, big things for you to be aware of is making sure that you're doing a good assessment. Make sure you're noticing if the patient's having any kind of uremic symptoms. Remember our uremic fetor, which is the acetone smelling breath, and uremic frost, which is a white type of frost from the urea escaping the body any way it can. So diagnostic measurements, we're going to be examining blood, checking the kidney enzymes. So our kidney is upset, so our BUN and our creatinine is going to be elevated. Our GFR is going to be decreased as a result of this. Sodium retention, we often have diluted hyponatremia because what happens is your sodium levels are normal. Once you start holding on to that fluid, then that dilutes your sodium concentration. So you have the sodium retention diluted hyponatremia. ABGs, because the kidney regulates acid-base balance within the body, and specific gravity is going to be around 1.01 despite fluid intake, because what's happening is the fluid is not being processed by the body, by the kidneys, and so you tend to retain fluid with glomerular nephritis. This is a slow progressive disease. One of the best ways that you can treat it is through prevention, and you want to do frequent assessments to be able to examine your patient's condition so you know what you need to do to be able to treat the symptoms. Eventually, the kidneys stop processing fluid. As the kidneys stop processing the fluid, they're not able to get the fluid out of the body. So dialysis will be needed or potentially a kidney transplant to be able to help regulate the acid-base balance, regulate the electrolytes, and regulate the fluid balance of the body. Nephrotic syndrome. With nephrotic syndrome, you see the glomerular permeability increase. This allows big molecules to pass into the urine and be excreted. So what happens is instead of retaining the good stuff, your body is just dumping everything into the urine. So you're losing lots of protein into the urine as a result of losing albumin into the urine. You're going to have third spacing of fluid. And the most common cause is changes with your immunity due to inflammation. So think of this as an immune kidney disorder. So increase in glomerular permeability allows the large molecules to pass through. They're excreted out and gotten rid of. So therefore, this causes a massive protein loss and you have a drop in your albumin levels. Your liver can also become involved with this as well and try to compensate. The way it tries to compensate is by increasing lipids, which causes a variety of other negative effects as well. So with nephrotic syndrome, we need several other healthcare providers to be able to help us with this. One of the main features is that you're dumping protein and you're not retaining it in the body. So you're going to have problems maintaining your blood pressure. You're going to have problems with sodium, and you're going to have problems with your hydration status. So you're going to be experiencing fluid overload because the fluid is actually third spacing instead of staying in the blood where it needs to be able to help keep the blood pressure up. So we treat this by helping to modify the process that's causing the disorder. So patients will be given pril medications like lisinopril, ACE inhibitors. This decreases the protein loss. Be given heparin. Heparin will help us decrease clotting, and this will help to improve the kidney function. The blood will flow better through. Dietary changes, we may need to restrict proteins, give our patient mild diuretics and sodium restriction to help control the swelling and to help control hypertension. And our hydration status, people are often dehydrated with this condition despite um, despite the third spacing and the swelling. Nephrosclerosis. Sclerosis means a change within the kidney blood vessels. So they tend to get thicker. As these blood vessels get thicker, the insides get smaller. So what happens is the kidney is actually starving for blood because of the thickening within the blood vessels. This often is common with hypertension, arteriosclerosis, or diabetes. Remember diabetes, we talked about the heart is trying to push around maple syrup within the body instead of blood. So this can be reversible if we treat the causes, or it can progress to end-stage kidney disease. So as hypertension increases, what happens is it drastically increases the kidney damage. So most common kidney damage is going to be caused with blood pressures above 160 over 110. And again, this may be reversible with treating the hypertension, or it can end in end-stage kidney disease. So big things we need to do is make sure that we're controlling the hypertension with diuretics and ACE inhibitors, and that we are improving the amount of albumin that's within the blood, not being dumped from the body. Okay, we're going to stop here for this lecture, and I will see you again in the next lecture. Thanks. Bye.